Thank you. And after invoking the blessings of the Almighty, it is indeed a pleasure to have with us once again another internationally renowned speaker, Dr. Tesfaye Horiza from Ethiopia, who will be speaking on making abortion safe, challenges and opportunities. So without wasting much time, I would request our president of KSOGA, Dr. Kasturi Donimat, to welcome the gathering.
Good evening to one and all. A pleasant evening, and my pranams to all the Kasoga KCOG members. As always, KCOG is doing excellent work with many luminaries as a speakers, and my very special thanks to Hema Divakar Madam, Dean of this Kasoga KCOG platform. Her brainchild, which she has started for the first time, any state association has started this KCOG program. So it was her thought, and it's going on excellent. And people look forward for all the KCOG programs. And as always, Hema Divakar Madam pitches in very eminent faculty, especially international faculty. Thank you, madam, because of the wisdom from such. Today, topic for the today is making abortion safe. Very relevant topic, because no mother should have any problems due to abortions. So it is a duty of each one of us to see to it that every abortion is safe. And to talk this, we have a very eminent luminary faculty from Ethiopia, Tesfaye Horiza. Thank you, madam. And thank you, Dr. Tesfaye Horiza, for accepting our invitation and joining all the way from Ethiopia. It's an honor to have you, and from Kasoga KCOG, and all the many delegates have joined. They're looking forward to hear from you and take home lots of take-home messages and excellent academic extravaganza. They all are waiting for, so I'll not come in the way. Thank you once again the whole Kasoga family for taking up such here. Thank you. And
yes, thank you, madam. And I will now request the Dean of the KCOG, Dr. Hema Divakar, to introduce the guest speaker to the audience. Well, all of us are familiar with Dr. Hema Divakar, so we are skipping her CV. As she
someone from Shield Healthcare wants to say a few words.
Yes, please. Okay, I'm sorry. Suman?
Yes.
Yes.
So it is our pleasure to introduce Dr. Hema Divakar Madam, and all of us know Madam, but it's my formal responsibility to introduce her once again. Madam is the Medical Director at Divakar Specialty Hospital, Senior Consultant OBGYN, and Madam is the CEO and Chairman Artist Dean KCOG, Chair of Well Women Healthcare FIGO, first
Yeah,
president of
thank you,
Foxy
Suman. We just wanted to share you.
Thank you.
That's all. Because we
And
respect your and value your presence. So now you can stop the slide share, as Bharti said. You know,
okay,
it was
thank you
more
very
to
much, madam. And over
it
to
was
you.
more to know
Yes.
Suman rather than
Yes.
Hema Diwakar. So because behind
Thank
the
you.
scenes, I think Shield Healthcare has been of a great lot of support. Suman Shitkala, who are here with us. If Tesfaye can also switch on his video for a minute, so that our esteemed president, Dr. Kasturi Donimat, and the honorary secretary, Dr. Bharti Rajshekar, can
Have a photograph.
welcome you. Tesfaye, your video on, please. Can
Remember, you're asking for me?
Yes.
Yes,
Thank
no,
you.
no, Tesfaye's video. Yeah. Hi, namaste again from the great team here. And the other people you can see on the screen is
Diwakar.
Dr. Diwakar and Sheetal Joshi from Team Artist. Tesfaye, we are so happy to have you here. And as the audience would notice, there were small technical glitches which delayed the start of the program by a couple of minutes. And in Ethiopia, whenever Tesfaye has joined us, many times he's very apprehensive about the connectivity, etc. But Tesfaye, believe me, we are strongly connected by many issues with women's healthcare in 2 different parts of the world. And just to put in the perspective, the starting prayer, which is always so important to each one of us here, and I'm sure in your own country, is together we light the lamp of knowledge and share each other's experiences and move in our journey towards doing our best for the women anywhere in the world. So welcome again. And we know that you've sent in your recorded talk, but we really appreciate that you're here with us live, and the audience will shoot their questions at the end of the session as well. Would you like to say something before we begin, Tesfaye? Is he frozen or is he on? Okay. I would just like to briefly and formally introduce Tesfaye with his formal curriculum vitae. No, Chitkala, let me just share the slide, please. Because I have a little bit elaborated his CV to say the right things. That is why Jay had made a 1-slide CV, which wouldn't really do justice to the achievement of Tesfaye. So I have just expanded it to a couple of more slides. He is the program director at the St. Paul's Institute of Reproductive and Health Rights at Addis Ababa, Ethiopia. He's a medical officer at the WHO. So he is the who is who of the World Health Organization at Geneva, Switzerland, associate professor of OBGYN with subspecialty training in family planning and reproductive health. And that's where the importance of what he's going to address us today. As you remember, decades ago, when Dr. Kamini Rao was the president of FOXI, her theme was Safe Abortion Saves Lives. And we are still echoing the thought that we really need to do something to make abortion safe and save lives. St. Paul's Hospital, Millennium Medical College at Addis Ababa is where Tesfaye holds a post of assistant professor. He's a quality director of the hospital Millennium Medical College, must trainer of structured on-job training. And we were just talking about the task sharing and task shifting. We will source him as one of our experts for work in this part of the world as well. He's a postdoctoral research fellow at WHO. And he has more than 11 years of experience at the national and global areas and the space of reproductive health, with special interest in research, policy, and programmatic work. All of us from the professional organizations have recognized more and more that we need to make our voices heard to the policymakers and implement the programs nationwide to get the needle moving further for the better care of our girls and women. He's published scholarly articles in national and global reputed journals, and many honors and awards to his credit, right from his very young age as a young researcher award for the best poster presentation, and the journey continues. So Tesfaye is going to speak to us on making abortion safe. Of course, we have plenty of challenges which are similar in India and Ethiopia, and there are many, many opportunities to circumvent that. So once again, with my heartfelt thanks, not only to the distinguished speaker, but also to our office bearers, Kasturi and Bharti, we would request Tesfaye to begin his talk on making abortion safe, challenges and opportunities. Tesfaye, please. Tesfaye's message has come. He's back with us. Yes.
Thank you so much for the very warm introduction. So, as it has been introduced, I will be talking on a very important and timely topic, that is making abortion safe. So we'll see what are the challenges and opportunities. So I have no conflict of interest to declare as it relates to the topic that I'm talking. And these are the outlines of my presentation. So I will go through the basics of safe abortion care, a clinical assessment, and some management of safe abortion care and post-abortion care. And finally, we'll talk about some of the legal as well as the clinical challenge of managing abortion. So most of my talk is based on the recently published WHO guideline. So what is abortion? So abortion is generally defined as termination of pregnancy before the age of viability. So the gestational age for viability depends on several factors, and different countries have different gestational age cutoff point. For example, in Ethiopia, we use a gestational age cutoff point of 28 weeks. This is considering, our neonatal intensive care unit facility, and based on our local circumstance and context, the chance of viability before 28 weeks is nil. So any pregnancy termination before 28 weeks is considered as an abortion in our setting. But this is basically different among different settings based on the level of care they provide for fetus and the chance of survival. When we talk about safe abortion, usually the core point when we say safe abortion is the use of evidence-based practice in abortion care. So what do we mean by evidence-based practice? So when we say evidence-based practice, usually we talk about three elements. So the first element is using the most updated research finding in abortion care. The second element is it speaks about the person performing an abortion. So the provider should have the necessary knowledge and skill as it relates to provision of information or provision of the actual intervention or the actual provision of medication. The third element is personal value and preference. So when the literal meaning, usually people misinterpret as evidence-based practice to be using just the data, but that's actually wrong, because the patient must be at the center of the care, and the person performing this abortion has to be also an important component of evidence-based practice. So when we see the global picture of safe abortion, nearly half of pregnancies globally are said to be unintended, and 1/3 of all pregnancies end in induced abortion. So we can confidently say that abortion is one of common phenomena in the reproductive age of a woman. So it's really important to make this procedure as safe as possible, and the most evidence-based practice should be followed, and the patient value and preference should be at the center of the care. So this is a graph showing a recent estimate by Guttmacher Institution. So as you can see from the figure, over the past 2 decades, there is a slight reduction in unintended pregnancy, and at the same time, there is a slight increment in abortion. The other very important finding of this recent estimate by Guttmacher Institute is that in areas where abortion is restricted, unintended pregnancy rate continues to be high. So this means by restricting abortion, by putting restrictive law on abortion, you cannot reduce the occurrence of abortion, but you make it unsafe and you lead to, you force or indirectly you push the woman to, go to the unsafe course, which will lead to complication of abortion, which finally leads to morbidity and mortality. So let's see important pre-abortion assessments. So when we talk about pre-abortion assessment, usually 2 important points will stand out as an important component in this pre-abortion stage. These are provision of information and counseling. So these two terminologies which looks similar are actually different, especially when we talk about safe abortion care. So when we say sharing information, this is usually a one-way communication. So you can take an example of, an outpatient clinic that displays, a TV, which gives an information on abortion or information on family planning or contraception. So there is a one-way communication, and there is no place for, asking questions and also receiving feedback. So in pre-abortion care, when we say sharing information, we can communicate the woman about the pain management, what are the things that we do during the procedure and after the procedure, what will be the experience of the woman during the procedure, and also, the potential complication of this procedure. So these are things that we are going to tell the woman during the process of abortion. But when we say counseling, this is actually very broad and usually involves a two-way communication by which the provider communicates with patient, and the patient will ask questions, and then there is, this mutual understanding, asking question and receiving feedback. So when we counsel a woman, there are some important elements that should stand out and that we should not forget during our counseling. One is, use a very simple language that can be understood by the woman. So let me give you an example of our country's context, or the context in Ethiopia, to explain what we mean by simple language. So, for example, in our country, the patients have, most patients uses a native language, but most, the medical education is in an English language. So we usually find ourselves in a difficult situation, interpreting some of this English language into the local and native language. So it's very important to make sure that what we speak is, translated accurately to the patient. So that's what we mean by using a simple language. Otherwise, using medical terminology will lead to unnecessary misunderstanding by the patient. So the provider should make sure that the language is translated accurately and a simple language is used during the process of counseling. The other important issue is avoiding, imposition of personal values and beliefs. So every provider has its own personal value and beliefs, but it's very important to put the woman as a center and to avoid, imposing personal beliefs. The other is ensuring privacy, confidentiality. This is another very important issue. So for informed decision-making, we need to make sure that the woman's confidentiality and privacy is maintained. So this process will help the woman, to have a clear understanding of the situation and to make, an informed decision-making. So when we say an informed decision-making, all scientific evidences should be put on the table, and the woman should understand the accurate information and then make a decision both based on that scientific information. So usually part of this decision-making process is, selection of whether to go for medical abortion or to go for surgical abortion. So there are several literatures that has compared medical versus surgical abortion. So accurate information in terms of safety, effectiveness should be forwarded to the woman so that the woman can make an informed decision. So let's proceed to the clinical assessment. So when we talk about clinical assessment, similar to other, service seekers, important information like gravidity, parity, any medical illness or allergy to any of this abortion medication should be sought and should be asked. And then following this important, the important milestone is gestational age determination. So what shall we use for gestational age determination? So the current WHO recommendation mentions that last menstrual period alone or in combination with the use of validated tools. Okay, so these validated tools could be mobile apps or checklists or pregnancy wheel. So LMP alone or in combination with these validated tools can be used effectively to determine the gestational age of a woman. But in some cases, when the woman doesn't remember her LMP or this method cannot be used, again, physical examination or ultrasound can be used to determine the gestational age. So when we say physical examination, we mean by pelvic examination or biomanual examination or digital vaginal examination. So that should be reserved to situations where we cannot ascertain the gestational age based on last menstrual period or use of these checklists. But routine use of ultrasound to date a pregnancy is not recommended. And also the justification of ruling out ectopic pregnancy to use an ultrasound is not recommended. It's not currently recommended. And usually making ultrasound as a necessity or as a mandatory for providing safe abortion care will put a restriction to the woman, and it will delay the time that the woman will seek an abortion. And there is no evidence-based justification that use of ultrasound can improve safety or can improve effectiveness. But for both, when you count, this is for the first trimester pregnancy. When you come to the second trimester pregnancy, the same rule will apply. When we come to the laboratory investigation, the other outstanding question is the determination of blood group and RH, routine determination of blood group and RH, especially at the gestational age of 12 weeks. So recent, systematic reviews conducted in different countries have shown that the risk of RH sensitization, in the first trimester of pregnancy or at a gestational age of less than 12 weeks is very minimal. So routine blood group RH determination and routine provision of anti-D is not recommended, and absence of, this blood group and RH should not be a restriction to provide an abortion care. So this is for gestational age of less than 12 weeks. But, for gestational age of more than 12 weeks, again, the other routine care like determination of blood group RH and provision of anti-D should be a standard of practice. But for those less than 12 weeks, whether it is medical or surgical, routine administration of anti-D is not recommended. And in settings when blood group RH cannot be determined, it should not be a bottleneck, to provide safe abortion care. So there are some important precautions to the use of medical abortion. So we need to rule out any allergy to commonly used medical abortion regimen like mifepristone and misoprostol. If there is any clinical suspicion of ectopic pregnancy, that should be ruled out. Chronic adrenal failure, intrauterine divide in place, hemorrhagic disorder leading to anemia, and severe steroid-dependent asthma should be ruled out. And if these things exist, further evaluation should be done, and other appropriate methods of termination of pregnancy should come into the picture. Again, with the use of surgical abortion, we have to see for this important clinical condition. For example, in a woman with hemodynamic instability and woman with myomatous uterus, with suspected chorioamnionitis and placenta previa, we have to be cautious and we have to individualize our care. For example, in a woman with myomatous uterus, we have to ensure that we can safely employ the surgical abortion. Because of the distorted uterine cavity, the procedure could be difficult, and necessary anticipation and preparation for complication should be made before proceeding with the safe abortion care. The other important part of management is pain medication. So pain management should always be available, and it should be administered in anticipation of the onset of the pain. So it should not be given after the patient has started feeling pain. It should be anticipatory. Several factors will determine, the provision of pain medication. Some of these are, the local regulation, safety consideration, and also infrastructure and resources also play a critical role in determining which pain medication to provide. There are other factors, which dictates the use of pain medications. In some group of patients, pain during the procedure is very much exaggerated, but some group of women tolerate pain much better than the others. For example, if you consider parity as one factor, preemie-gravid or women with their first pregnancy tends, to feel severe pain when they are compared to women who has previous delivery. So our pain medication should be dictated by these factors: history of dysmenorrhea, pre-procedure anxiety, and also age of the patient. These are, important factors that we should see when we are, trying to administer pain medication. So which pain medication shall we choose? Always the patient is the center of the choice. So the patient can choose from no analgesia at all to the highest level of pain control in the facility. So always discuss with the patient and then select the appropriate pain medication. In some cases, if we cannot provide, the pain medication that the woman requires, some also recommend us even to send the woman to a site or a place where she can receive an appropriate pain medication. This is to stress the importance of, administering pain medication in abortion care. So let's see the methods of abortion. So universally, there are two methods of abortion that we employ: the medical abortion and the surgical abortion. So medical abortion one is mifeprostol with misoprostol or misoprostol alone. But current studies have shown that letrozole with misoprostol is also another regimen that can be used as medical abortion, which I'm going to discuss in the subsequent slides. The other is the use of surgical abortion. So it can be manual vacuum aspiration in the first trimester and dilation and evacuation in the second trimester. So what are the medical abortion options? So currently, WHO recommends either use of mifeprostol plus misoprostol, what we call it a combination regimen, or misoprostol alone as a management option for medical abortion. But it's clearly documented that the use of the combination regimen is much better in terms of effectiveness than using misoprostol alone. The other recently recommended medical regimen for management of medical abortion is the use of letrozole plus misoprostol. So this is included in the new WHO recommendation, and this is based on a systematic review which was conducted in Egypt, Islamic Republic of Iran, and China. So this systematic reviews has compared letrozole plus misoprostol versus misoprostol alone. And consistently, it has shown that letrozole plus misoprostol is much effective than using misoprostol alone. So after this finding, WHO has recommended, the use of letrozole plus misoprostol as an option of medical management. So basically, letrozole is similar to mifeprostol. and it can be used, it should be always used with misoprostol. When you see the mechanism of action, it works by suppression of estrogen levels, which modifies the progesterone receptor concentration. So this will subsequently lead to pregnancy loss. So in setting where letrozole is, available and registered, letrozole plus misoprostol is another important drug that can be used for safe abortion care. So let's see specifically the regimens that are used in medical abortion in the, at the gestational age of less than 12 weeks and at the gestational age of at or above 12 weeks. So at less than 12 weeks, Mife with miso is recommended as a first-line regimen. So Mife 200 milligram orally followed by misoprostol 200 milligram after 24 hours is recommended by World Health Organization, and the minimum interval between Mife and miso should be at least 24 hours. And the second option is the use of letrozole with misoprostol. So 3-day course of letrozole 10 milligram followed by misoprostol 800 microgram on the 4th day is the current recommendation. When it comes to medical abortion at or beyond 12 weeks, the same combination regimen of Mife and miso is recommended, and the interval between Mife and miso similarly should be minimum of 24 hours, and the frequency between misoprostol should be every 3 hours. So the other is medical management of missed abortion at gestational age of less than 14 weeks. So currently the use of combination of Mife with miso or miso alone is recommended for management of missed abortion at gestational age of less than 14 weeks. So Mife followed by 800 microgram misoprostol is the recommended one. And when you compare this to the combination regimen, this is more effective than using miso alone. The other is management of intrauterine fetal days at gestational age of between 14 and 28 weeks. Again, 2 options have been put as an option. The first is a combination of Mife with miso, and the other is miso alone. So the combination regimen is again has a little bit more effectiveness than using the miso alone, and the interval between miso should be every 4 to 6 hours. So it's good to see this difference, in interval, between each miso. So for a safe induced abortion, every 3 hours is recommended, but in case of missed abortion or intrauterine fetal days, every 4 to 6 hours interval is recommended. Again, for incomplete abortion, both medical and surgical options can be used. And for those gestational age of less than 14 weeks, 600 microgram misoprostol orally or 400 microgram misoprostol sublingually are recommended. And for incomplete abortion beyond 14 weeks, 400 microgram of misoprostol every 3 hour anterior expulsion is currently recommended. So, but some women, again, they may prefer to, to have a conservative management and to observe, to see until, they spontaneously expel rather than, receiving medical management. So value and the preference of the woman should come into the picture. And if the woman opts for conservative management, the risk should be told and she should be offered for conservative management, for a reasonable period of time. So which method shall we use? So medical or surgical abortion? So always, a two-way communication, or what we have discussed on counseling, should be there. When the decision is, provider-driven, there is a risk of making assumptions, and there is also an issue of paternalism. When the decision is, based on the patient, there is a risk of information overload, and usually the woman will get into trouble making an informed decision. That's why we advise, a bilateral discussion with the provider is important to make an informed, shared decision, and there should be an adequate information transfer between the provider and the patient. So there was one commentary that I read, which was written by a primary physician. It says, communication is not important in a health center. Communication is a health center. So this is to stress how communication is actually very important aspect of our management. So this is a study which was conducted in our setting, comparing medical versus surgical abortion in a woman who were managed between, the gestational age of 13 to 20 weeks. So around 270, more than 270 women were enrolled. Out of this, around 60 were surgical and around 219 were medical. So this is basically the comparison between medical abortion and dilation and evacuation. So the result of this comparison was, in terms of composite complication, there was no significant difference between medical and surgical abortion. But more women in medical abortion were observed for bleeding. More women in the medical arms were having a continued bleeding for 2 weeks, and significantly larger proportion of women in the surgical arm will also recommend the same procedure to other individuals. So the target is, moving toward this evidence-based patient-centered care. So we have to drop assumptions, options, whether it's medical or surgical, should be explained, and women should be, encouraged to have a discussion on their values, and we always need to advocate for the patient. The other, one of the challenging concepts or one of, a concept that's considered as, a challenge, actually a challenge in provision of abortion is consciousness objection. So consciousness objection is basically refusing providing abortion care for personal value or for personal beliefs. So it is said that unregulated consciousness objection can result in human rights violations. It also leads a woman to seek unsafe abortion. So it imposes a burden on the health system. So the issue of consciousness objection is actually addressed differently in different contexts. Some countries allow consciousness objection, some country doesn't allow consciousness objection, some country allow consciousness objection under only certain circumstances. But WHO has advised, the health system should be organized in such a way that it ensures an effective exercise of the freedom of, conscience of health professional in the professional context doesn't prevent patients from obtaining access to services to which they are entitled under the applicable legislation. So this is to mean that, the health system should come up with some mechanisms that important cares, including safe abortion care, should be provided even in the presence of, some consciousness objectors. So what are, some of interventions that can be done at the health system level to reduce this challenge of consciousness objection? So one is organizing the health system in a way that, sufficient non-objecting providers are employed and distributed fairly across the country. So if you take one setting or one hospital, and if all the providers are objectors, then the woman will suffer to travel to other hospital or sometimes to the other country, other city in the country to get the service. So this will somehow will put a challenge to the woman in accessing abortion. So ensuring that, equal distribution of consciousness objectors in settings will somehow alleviate this problem. And the other is putting a clear and enforceable regulations of consciousness objections, and that requires, objectors to provide a rapid referral to accessible non-objecting providers. So facilitating, an easy, smooth referral and putting, holding responsible the objectors if there is no timely referral is somehow, it's going to help the woman access the abortion care within the limited or within the specified time. The other is outlining clearly who may object to what component of care. So there are different components of care, including, provision of information and providing an actual care. And also there are different components of, abortion care components, starting from safe abortion care and post-abortion care. Some of these care are quite important in life-threatening. So putting legislation that clearly delineates that this type of care cannot be objected is really important for a woman to, get the service, at least some of the important services, such as an emergency conditions. So again, sharing the example of Ethiopia, we have a straightforward document which says that a provider cannot object this for 3 types of care. So one is safe abortion care, the other is family planning, and the third one is blood transfusion. So a provider in Ethiopia cannot object to these 3 clinical conditions. So it's very important to have such kind of, a clear health system law or rule which ensures the woman who needs care can actually receive the care. So the other is self-care. So self-care is not a new concept, but currently there are much more evidences emerging showing that self-care is safe and effective. It has different components, starting from self-assessment until assessment of success of abortion. So in areas, in some of the areas where abortion is very restricted, self-care is the only option for a woman to get the care. So the health system should facilitate at least a way for a woman to access different components of self-care in a setting where health facilities are not ready to provide the care. So WHO currently recommends self-care, self-management until 12 weeks of gestational age. When we say self-management, it includes all components starting from eligibility assessment, self-administration of medicine, and self-assessment of success of abortion. Interestingly, more evidences are emerging on self-care even beyond 12 weeks, and things may change as more evidences emerge. The other is decriminalization of abortion care. So when we say decriminalization of abortion care, we are saying that treating abortion similar to other healthcare services. So it means using the best available evidence for service delivery, training of providers, development and application of evidence-based guidelines, and also applying existing law to deal with any dangerous or negligent practice. So what are the components, or what are the things that we talk when we talk about decriminalization of abortion? It means not punishing anyone for providing abortion care, not punishing anyone for having an abortion, not involving the police in investigating or prosecuting safe abortion provision or practice, and not involving the court in deciding whether to allow an abortion. So finally, I want to share an interesting case that we managed in our setting. So this is a 20 years old, premi-gravid woman. Initially, she was referred from a health center. They have seen her, evaluated her, and they thought something is wrong with the pregnancy, and they referred to our tertiary health facility for a better care. And upon arrival to St. Paul Hospital, where I was working, we did a baseline ultrasound, and there was some serious congenital malformation, which was diagnosed in this patient in the fetus. So there was a fused chest and abdomen with single shared distorted heart. There was a single aorta, umbilical cord, and liver. The kidney has also some abnormalities, but separate spine was seen, and we diagnosed a case of conjoined twin with thoracoemphalophagus was diagnosed, and this case was discussed as a multidisciplinary team, and the viability was also discussed, and it was diagnosed as a lethal congenital malformation. Since the gestational age was beyond 22 weeks, the possibility of medical abortion and vaginal expulsion was unlikely, considering the wider diameter of the conjoined twin. The other option that we had, was doing hysterectomy. But, especially for a woman coming from rural area, putting a scar or giving a uterine scar was something that we don't encourage in our setting, because, the risk of subsequent rupture is very high, especially considering, the distances that they have to travel in order to access a cesarean facility. So considering this all, we gave her an option of dilation and evacuation, and the woman has agreed. After taking a consent, we start, the process of preparing the cervix. So we did 2 days of serial of, cervical priming using laminaria. On first day, we put 5 laminaria in the cervix, and on the next day, we removed the 5 laminaria and inserted another 10 sets of laminaria. And then on the third day, we removed we put, as the laminaria was there, we put a misoprostol, and then with 2 serial days of laminaria and misoprostol, we proceeded with the dilation and evacuation. So after 2 hours of misoprostol, the woman was transferred to the operating room, and spinal anesthesia was provided, and dilation and evacuation was done under ultrasound guidance, and the procedure was completed with no complication. We followed the woman as an outpatient, and she had a smooth post-procedure course. This is a case that I have. Thank you very much. I'm open to have discussion, comment, or any kinds of suggestions. I'm very open to receive. Thank you very much.
Thank you so much, Tesfia. Safe abortions, or making abortions safe, seems to be an evergreen topic, if I may say, because for centuries we've been discussing that, and then there is always more to discuss. So just a couple of questions from our audience here. The first question is, they want a little more explanation about the letrozole regime for medical abortion, because many people don't seem to be using it here. So can you just re-explain to us whether that works better, or what is your choice and why?
Can I go ahead and answer this question?
Yeah, please.
Okay.
And
Okay.
Chitrakala, you have to just have Dr. Bharti also have a video on, please. Yeah.
Sure.
Yeah, please,
okay.
Tesfia, please.
Yeah, okay, thank you very much. So the evidence on letrozole is a new one. So the currently updated WHO guideline has incorporated letrozole plus misoprostol as one option of pregnancy termination until 14 weeks of gestational age. So this was following a systematic review which was conducted in 3 countries. So in Islamic Republic of Iran, in Egypt, and in China. So this comparison was done between letrozole plus misoprostol in one arm and misoprostol alone in another arm. So this comparison has consistently showed that letrozole plus misoprostol is much effective than misoprostol alone. So following this, WHO has recommended the use of letrozole plus misoprostol as a regimen. When we come to the use of this combination regimen, the first 3 days will be we will administer letrozole 10 milligram orally for 3 consecutive days, and then on the 4th day misoprostol will be administered. So this is how we use it, and it depends. In some settings this practice is right and left, but in some settings the practice is not there yet. But this is just to say that it's it's one option of managing safe abortion in settings where they can have letrozole and misoprostol as an option.
Yeah, but Tesfia, you said 14 weeks. Does it work in such 11, 12, 13 weeks? What is the kind of failure rate, and what has been your experience beyond the research setting?
Yeah, so this is just a research finding. So in terms of clinical practice, so currently we don't use letrozole in our country especially for safe abortion, because we do have easy access to mifepristone and misoprostol. But this evidence is based on, the research findings that existed specifically in these 3 countries. And it has consistently shown, effectiveness until 14 weeks. But effectiveness beyond 14 weeks, I think there are no much evidences, and hopefully more evidences will emerge. But I think, again, in some settings, there is an issue of registering mifeprostone. So mifeprostone access could be a challenge in some settings. So this could be a health system consideration, because rather than using misoprostol alone, in contexts where they can access letrozole can give them a leverage, and they can use it in combination with misoprostol.
Okay, that leads to my next question from the audience, which says that in India, it's very common to get this over the counter from the pharmacist. So how is the situation there in Ethiopia? Is it licensed through the doctors, or do the women just go and ask for abortion pill and somebody gives it to them, or how does it go?
Yeah, so with regards to mifeprostone and misoprostol, so I will tell you both, what the government recommends or what the policy says, and then what the actual practice is. So the recommendation currently is there is no place for, self-management. What we have is the woman should go to a clinic, a health facility, and eligibility assessment should be done by a provider. After eligibility assessment, then she can go home with both mife and miso to complete the rest of the management. So taking the medication and also ascertainment of completion can be done by the woman, but eligibility assessment should be done by the healthcare provider in a health facility. So this is what we are practicing currently, but there are inconsistent findings that women can use informal sources to access these medications, and I know that there are some research undertakings to explore how the practice is, how safe it is, but as a country, as a protocol, this is the national guideline, and this is how we work.
Right. I think Dr. Bharti has a series of questions which is put in chat box. Go ahead and ask it yourself, Bharti.
Dr. Tesfaye, one thing I wanted to ask you, you said that the guidelines are being looked into for self-assessment and self-assessment of the completion of the procedure for the choice. How safe do you think this is? Because in our country, we are seeing women like Dr. Hema said, taking the mifo and mifepristone over the counter, and they'll end up with morbid anemia, hemorrhage, sepsis. And I somehow feel that you said that research is going on, but how safe do you think it would be?
Yeah, so I think this is a challenge that we have. I'm so happy that you raised this question. So the practice is different. We also see the same thing in our country. Women getting to, going to the pharmacy, buying the drug over the counter, and then, come with a bleeding. So now we do have 2 options. One option is restricting the pharmacies, putting a very strict legislation, and then avoiding the pharmacies, to stop giving medications to this woman. This is one option. The other option is, what if, teach or bring the pharmacists to the health system, and then, give them some information so that they can administer the drug safely. If we teach them, if you give them a small training, then they will be able to educate the women, they will be able to assess eligibility and then provide the proper care. So when we compare this to me as a provider, I would incline to the second option, because you cannot restrict the woman from accessing it through informal resources, because that's the way. For some women, that's actually a choice, because they don't feel comfortable to go to the clinic to be seen by the doctor. So whatever laws that we put, whatever law restrictions that we put on the pharmacies, still women, go to the informal resources, go to the hotlines and over the counter to get the drug. So I think what needs to be done, and what I personally recommend, is bringing the pharmacies or anyone who is involved in the formal resources, in the formal settings, brings them and teach them how to provide an accurate information so that the woman can get, accurate information and get the service. And also the clinics should be open to manage these complications, and also providing important information 24/7 through hotline and others. So we should support what actually exists in the country rather than, pushing them, because whatever we do, women tends to choose what they want. So I think that's probably the way to go. But there are several arguments that are going on in our country. I know this is one of a challenging area.
Yeah, I think
thank
Bharti
you.
has already said that, she completely agrees with the idea of
I think that-
getting the pharmacists on board. So since Dr. Kasturi is also here and Bharti is here, they are the
Yes.
state leaders. And there has been a company called Integrace, which did recently a program called MTP Connect. And they are very, very keen on doing the baseline research on what really is the ground reality. How many women seek
over the
out of
counter.
the health system care, and also rope in the pharmacists at least for a sensitization and awareness program, so that they network with a cluster group of hospitals. So just in case they are forced to give the tablet away, they also give them a slip saying that if there is this complication, you go and seek help with this network. I think if our state, establishes this role modeling for the safety of the women herself, I think it will be a great step forward. So thank you so much for that input. There was one more question that Bharti wanted to ask, and then I'll hand over to Kasturi. Bharti?
Yes, Dr. Tesfaye, you said that you did the dilatation and evacuation for this lady with conjoined twins. How were you for spinal anesthesia, dilatation, got it? But did you do destructive operations and then remove the product of conception?
Yeah, so I think with this procedure, what we did was, there is a fellowship program in family planning and reproductive health. So this is a 2.5-year training after completing an OBGYN specialty program. So we take this training, on advanced gestational age, doing dilation and evacuation in advanced gestation. So for this woman, what we did was, it's a conjoined twin and the diameter is wide. So the options that we had was either doing hysterotomy or trying to do dilation and evacuation. Fortunately, we do have access to laminaria. So we put a total of 15 laminaria, for 2 days. So on the first day, we put 5 laminaria, and then on the next day, we removed that 5 and we inserted another 10 laminaria. On the third day, the cervix was quite open. So after that, what we do is under ultrasound guidance, we try to, remove the fetal parts by distracting and disarticulating the fetal parts. So yeah, it's not an intact process, because for the intact dilation and evacuation, it needs much dilation. So what we do is, opening the cervix to some level and then trying to, remove the contents part by part.
So, well, because you are given the mifepristone, the fetus is dead. So
yes, so
at the placenta has regressed, so bleeding will not be much.
It will not be much, exactly, yes. And she already have a contraction, and when you pull from down, the misoprostol will help you in contracting the uterus and, push all the products to the lower uterine segment. So your procedure field is the lower uterine segment, so that you don't have risk of, perforation and, injury to the internal organs. Yeah.
But avoids the scar on the uterus of this girl.
Exactly. Yeah. Yeah. We are a country of 120 million people, and then we do have less than 500 gynecologists, and getting a cesarean section is a very difficult option. The cesarean section rate in the country is, it's probably less than 6-7%. So we want to avoid scar as much as possible. Yeah. So this is one way out.
Thank you.
Yes, because laminaria tents and all, it's been like we
Historical
haven't seen it
for
or
us.
used it for ages, and it's not one of our preferred insertions in view of the infections that it can cause, etc., etc. Kasturi, our president.
Yeah.
Kasturi.
Thank you. Thank you. First of all, thanks to Dr. Tesfaye for such an excellent lecture, lots of take-home messages. And we really know what the healthcare scenario there and then here, and what we can implement in ground level here. And as you all told, this is giving the over-the-counter medicine is not only morbidity, we have seen mortality also because of very, very dangerous. I have seen at least 4-5 cases where patient, she missed her period, got a urine pregnancy test at her home. Just because it was positive, she went to the medical shop, took the tablets. Then she suddenly had pain abdomen and she came in a state of shock. We have seen so many cases like that. And one young girl, she came to her casualty, triage area, pulseless, BP-less. Before she could shift, she was no more. Just because she took over-the-counter medication, it was an ectopic pregnancy. Because it was positive urine pregnancy, she went to the tablet, she took those tablets, and when she came, it was ruptured ectopic. So we have seen a number of ruptured ectopic cases because they are not consulted a gynecologist or a doctor, and they have taken the over-the-counter drugs. So very, very dangerous. So we don't advise. I still teach all our healthcare workers, I feel whomever we come across, and wherever in a public platform, we tell them, you don't, just because you have missed a period, urine pregnancy test, please don't go to a pharmacy and take tablets. It can be dangerous to your life. So we are spreading that message and telling the people we should see. But in spite of that, I see so many people doing that. Many people, even if they have one person in their home doctor, they just call up like, I missed a period, my UPT is positive, what shall I do? So Ayurvedic doctor or somebody, they just advise that, and because of the over the phone or WhatsApp, they take and they land up in problems. So this should totally go. Taking over the counter medicine, unless they have talked to the doctor, have clearly examined, ruled out ectopic, they should not take any of this things.
Kasturi, the girls and the girls and women also need to be sensitized to the fact that such dangerous consequences can happen. Because I've had a couple of patients who repeatedly use this abortion pill. They don't use contraception. They have used it once and they have found everything so cool. Then they have again used it, and then they're telling a lot of their friends that, oh, nothing happens, I just buy it, I just do. So that sells so well in the community that everybody thinks it is so cool and so easy, because many of the young people with premarital sexual activity, many of them on the digital platforms are into these kind of circles or forums, which is like, it's also becomes our duty to sensitize them that, hey, once in a while, like how accidents happen, this can be life-threatening and it can be as bad as that. So yeah, go ahead, Kasturi.
And on the other hand, what I'm seeing is they have missed the period. So they assume that they're pregnant and they just go to the pharmacy and they're taking this mifepristone and misoprostol, and then they come, we have taken these tablets, but still we have not got periods or little spotting only. Means they assume. So even without getting pregnancy test also, because this is so easily available, pharmacist is so easily, he gives the medicine as soon as they go. So this is one end is they don't get them tested. Even for delayed periods, secondary amenorrhea, they are taking one end. Other end is, even if they have ectopic without knowledge, they are taking and landing up in such dreadful, dangerous complications. I've seen even a doctor's sister coming like that, because the doctor knew about the tablets and he told and she took. And then he brought her in emergency, telling that, madam, I had given like this, and then it was an ectopic rupture full of hemoperitoneo. So this message should go. One is educating the pharmacist not to give and without the doctor's prescription. Other is telling the public itself, the adolescents, this thing, not to go and buy and endanger their life. And once again, thank you, madam, for bringing in such an eminent speaker on this platform, that too from Ethiopia, so long. And special thanks to Dr. Tasfiya for joining from Ethiopia and taking out time from their busy schedule. Thank you once again, and looking forward for more such innovative, very excellent activities for Kasoga and KCOG. Thank you.
Thank you so much. Just one last thing. about the use of ultrasound to locate the pregnancy before giving the pill. It is not there in the WHO guidelines. It's not recommended by the Government of
Yes,
India guidelines as well. That is because the earlier you use it, the better is the efficacy. And by the time you spend, first of all, access and detection of ectopic pregnancy may be, sometimes very tricky. And then you spend so much time and then you lose out on that time period where you could have given the abortion pill earlier. So there are many issues around this. So Bharti, that's a good question you've raised, but I think we need to, look at it a little differently, saying use an ultrasound. Maybe it's an advanced pregnancy. At least then you know that you should not use it. That also is a message that there is. So though the topic is simple, abortion, make abortion safe, and there are so many issues around it, but there has been such brain churning discussions even on this. So I thank our audience who will be more enlightened after Tesvia's deliberation today. And Bharti, the last word as usual is yours.
Yes, thank you, Hema. And Dr. Tesfaye, no words are there to express our gratitude for you for enlightening us on the updates and the challenges in abortion care. And it continues to remain challenging, as Hema said. Thank you very much for being with us. And on behalf of the entire KASOGA and KCOG team, we express our gratitude and we give you an open invitation to visit our country. We share a lot of challenges. Let us search for solutions and make it safer for women. I thank Dr. Hema Divakar for her vibrant presence as usual in the KCOG webinar today. Thank you, Dr. Hema. I thank our President, Dr. Kasturi Donimat, with her experience, vast experience as a medical college faculty. She has seen a lot of challenges and she has a lot of messages to take home to all the practitioners here. I thank the SHIELD entire team of SHIELD along with Mr. Suman Saha for sponsoring and keeping us updated and giving us an opportunity to meet people from all around the world and share our thoughts and take up all the tips from everybody. I thank Dr. Divakar, the man behind the successful woman here. And I thank Sheetal. I thank all our participants for taking part in this program. And in absentia, the office bearers of KSOG and KCOG who have not been able to join due to a busy schedule. We thank all of you. Wish you all a happy weekend. Stay safe and stay healthy. Namaste to all.
Thank you so very much.
Thank you very much.
Namaste.
Thank you.
Thank you so much.
Namaste.